All right, good morning. Welcome to the Wilson Center. If you were not here this morning in our morning panel, I am Sarah Barnes. I'm the project director with the Maternal Health Initiative here at the center. We are thrilled to be partnering this afternoon with World Vision to discuss healthy timing and spacing of pregnancies, faith-based engagement, and family planning. We are very pleased to welcome all of our panelists here today and grateful to World Vision for supporting this open discussion on these very critical issues. For those of you who are not familiar with the Wilson Center, we are a living memorial to President Woodrow Wilson, who is the only president to have received a PhD. The Wilson Center is nonpartisan and non-advocacy by law, and throughout our 50-year history, as a neutral forum, we've always strived to bring a variety of perspectives to the table. Today's events continue the Wilson Center's 20-year track record of sharing a diverse range of approaches to key global health challenges, including the very important contributions of the faith-based community. And with that, I would like to introduce today's moderator, Catherine Marshall, to the stage. Catherine is a professor of development, conflict, and religion at Georgetown University and the executive director of World Faith's Development Dialogue. Thank you, and welcome, Catherine.
Well, good afternoon, and let me join my welcome and invite Dennis Cherian to come and give us a greeting.
Thank you so much, Marshall. Respected Dr. Golden, distinguished panel, and dear participants. My job is very brief. I'm supposed to give an introduction. About 2 decades ago, World Vision began implementing family planning programs through its USAID Global Child Survival and Health Grants program. And I'm one of the products of that. When I started my career in '97 back in India, implementing USAID Child Survival Health Grants program. And an indicator we measured then was unintended pregnancies. And I thought it was an important indicator because it gave us an opportunity to talk about planning one's family, desired family size, and the impact on unintended pregnancies and child well-being and household well-being. Our approaches primarily then were working through non-faith-based groups, but basically through rural healthcare practitioners and other community health networks. And we saw that the impact was tremendous. I looked at the data just now, and it was amazing to see in the midterm evaluation 98 and the midterm that was concluded in 2002, our baseline figure rose from 8% to 38% of contraceptive use. Subsequently, we scaled up to 3 districts across the state of Uttar Pradesh with dramatic results. Over the course of the years, World Vision has been fortunate to receive funding not only from USAID, but also through the Bill and Melinda Gates Foundation and the Templeton Foundation, whose results my colleague will present today. Fast forward, based on data and our own experience, we shifted our focus to emphasize on healthy timing and spacing of pregnancy. Now, what does that mean? It means it is a phrase that helps us to better engage conservative populations or faith actors and to have a better conversation with mothers and families to talk about the well-being of the child and themselves. We also found that it resonates well with faith leaders and the faith community. We also found that Christian as well as Muslim faith communities could have a better acceptance to contraceptive work and uptake of contraceptive services. We also found that we had to teach them the how and what of HTSP. World Vision has a model called Channels of Hope that engages faith communities, not only for family planning, but for many other social and health and other issues as well. With funding from the Templeton Foundation, we were able to do an operations research on the impact of mobilizing faith leaders and uptake of contraceptive services. The results have been very inspiring. And our challenge was, how do we scale it, the program? And I think this program and the results of our work in Kenya and Ghana should not only shed light for the rest of our community of practice, but for us as an organization to see how do we scale up HTSP or other health issues using a faith lens. Today we have a distinguished panel that will share evidence of our work on channels of hope, and also we will hear from the rest of the panel on sexual health and reproductive rights as well. Thank you so much and welcome.
Thank you very much for that warm welcome, and let me invite Dr. Alma Golden to give us a keynote address.
Thank you very much. I'm very honored to be here, and on behalf of USAID, I want to express my appreciation for you coming today. I recognize we have some very limited time, and so I'm going to put my watch out here, but I understand I also get messages on my time limits. But when I take this off, it sometimes reminds me of a story I heard about a gentleman who had a friend come in from an international place, and he went to church with him one day, and as they walked in, the guest asked the host, he said, what does it mean that you took off your hat when we walked in? He said, that's to show respect. And then they looked at the bulletin, and there was a number. And he says, what does that number mean? And the host said, it's the number of the song we're going to sing. And then when everybody stood up, the guest said, why are we standing up? And the host said, it's because we're going to read scripture. And then the pastor got up, and he took off his watch, and he laid it down on the pulpit. And the guest said, and what does that mean? And the host said, absolutely nothing. So I'm going to try to make it count for something, okay? So I'm going to thank Catherine for the introduction, and also Dennis for the good overview in terms of how important family spacing and healthy pregnancies really are. I'm going to also thank the Wilson Center. Thank you very much. This is a lovely facility and my first opportunity to actually speak here. I also want to tell you that I was a little intimidated by the panelists. You have such an outstanding group that's going to be sharing today, and I'm looking forward to listening to the discussions that happen. Very appreciative of that. USAID was actually formed in 1961, and since that time it's been in this international space looking at how we can end extreme poverty and build resilience and stability, and how we can move our world to a more peaceful and a healthier place. And I think it's exciting that we've been here for more than 50 years, but I think if you look at the faith-based organizations, we're newcomers to that territory. What you and your colleagues in the faith-based space have done is really reach out for much, much more than 50 years and decades. It's been more like centuries. I will tell you that in 1961, when USAID was formed, I was actually a part of a little missionary organization at my church, and we got to listen to stories about people all over the world that were helping others. And I remember being so inspired by those messages. And it has a great deal to do, probably everything to do, with the fact that I decided to go into medicine and that I eventually became a pediatrician. It also has a lot to do with the fact that when I finished college and medical school and training, and I didn't have the opportunity because of family situation to do international health, I took the opportunity to run a maternal child health program in rural United States, in Texas, for a decade, where I actually got to do much of the same kind of work, where we offered children's services, and I did it alongside with family planning and maternity services as well. It was a really wonderful opportunity. And it sort of speaks to the fact that some of the needs across the world are very similar, whether they're in our country or in other countries as well. I want to acknowledge, too, that for many years, the faith-based partners have been very important to USAID. As was noted, USAID has been in India for, over 20 years now, but we've actually partnered with faith-based groups for over 30 years. And we've had, I think the last count I saw was somewhere around 44 different partnership projects with World Vision and their colleagues. I want to tell you that I noticed when I went and looked on the World Vision website, there are these wonderful quotes. Who does all of your quotes? They're just amazing. But like one of them that I really loved was one that says, dangerously soft-hearted, but just the right kind of dangerous. And I think that faith-based groups really have that capacity. They have this open, loving care that provides sort of an extra dimension to service compared to what we see sometimes in the secular healthcare delivery. And certainly I've been part of mostly academic and private healthcare most of my life, but I see the extra dimension of compassion that happens in faith-based groups. And I acknowledge that, and I applaud you for it. It really is a beautiful sentiment. It's a beautiful example of how you serve the world. Just that dangerously soft-hearted perspective. So I want to talk a little bit about some of the remarkable contributions that have been part of how faith-based groups have contributed to global health and development. I think one of the most important things is that you actually are at the community-based level. You're at the area where the intersection of need and resources actually happens so much of the time. You have a vision for the bigger piece, but you know how to take the global vision and take it all the way to the most vulnerable populations. And that's really an incredible gift to USAID, and one of the most important reasons why we need to partner with you. As I mentioned, since the 80s, we've had a number of partnerships. We've had at least 30% of our projects since that time have been with faith-based groups. And as a result, you've been an incredibly important part of actually significantly improving maternal and child morbidity and mortality. And particularly that's true in the high priority areas that USAID actually participates in. One of the things that's so obvious is that because of the fact that you've been in the countries for so long, you have an opportunity to establish a knowledge of the communities that is maybe not obvious to those of us who have only been there for 30 or 40 or 50 years. Some of the faith-based groups have really been there for over a century, and so you understand the way the system works, and you've built a level of trust that allows interaction that's very, very comfortable and very knowledgeable and very efficient. One of the things that we've noticed about religious leaders and faith-based in terms of reaching vulnerable populations is there have been some specific things that we've actually seen progress specifically with those groups. And that one of them is looking at postpartum care, how you've helped us to identify ministry, I guess you could use that term, and services to people who have just delivered, and integrating the motherhood with planning for the family, the next family pattern, whether they're going to have a pregnancy in the near future. As you know, we're all more and more aware every year of how critical the 1,000 days are during the pregnancy and in the first 2 years of life for a child. And as a pediatrician, I have to say I really want our mothers around the world to have the health benefits of a healthy pregnancy and then delay a pregnancy, and the health to be able to breastfeed and nurture a child up to age 2. And that's why I think we need to be so helpful in terms of helping communities to have this the healthy spacing and timing. What we do know that through IHR and other, I said it wrong, IRH. Okay, sorry, and other groups, we know so much more about how to space pregnancies now and how to help educate families as well, and that's why it's now termed your cycle beats, and other interventions are referred to as high impact practices because you've developed the sophistication around that. The other thing that we've benefited from your help on is to address stigma and marginalization of populations. Christian and religious leaders are very helpful in terms of identifying the social norms that may be detrimental to health and relationships. And I think from a Christian tradition, fighting stigma and addressing the marginalized people, whether it's women or children or people with disabilities or any other minority populations, we benefit from the example that is seen in Scripture, where Christ himself was addressing touching a leper, reaching out to a woman who was hemorrhaging, helping an epileptic, or actually assisting someone with mental illness. And that heart that becomes part of the outreach of faith-based entities. And I think it's an irreplaceable asset that you bring to us in terms of fighting stigma and marginalization. Some of the reasons that faith-based leaders are so effective in family planning is just what Dennis was talking about, recognizing how family planning goals are really met in terms of supporting the family. When we know that when you enable a family to be able to time and space their children, you actually improve the overall health of that family. And we've seen this in terms of improved child and infant health as well. As you can tell from the banner over here, we also want to be sure that the faith-based leaders are helpful in terms of addressing delay of pregnancy until a healthy time period, and then spacing after that. And I think the 18-year-olds, from a pediatric perspective, all of us know that not only are pregnancies more problematic prior to age 18, but other sexual infections and the tears that occur during delivery and so many other problems can occur. So we're delighted with the spacing that this recognizes. One of the things that we also address is just the benefits to the child of this healthy spacing and timing. It's easier for a mother who is well-nourished and not anemic to have a child who's fully mature and also capable of a healthy birth weight and able to tolerate those first few days of life that are so problematic. We are on track to improve our healthy timing and spacing in our 2020 goals. We're hoping to be able to demonstrate that we've saved at least 450,000 women's lives just by virtue of some of the simple improvements that we've made, not only in timing and spacing, but also in basic maternal care. And we applaud the role of the faith-based groups in that as well. So, how do we implement your expertise, and also how do we recruit more assistance from a faith-based plan? First of all, we want to be sure that we develop relationships and that you stay in touch with us and that we share ideas. Like, I'm excited about getting to stay for the next 2 hours and participate and listen as you discuss the issues today. And then also let us know how to help you in terms of preparing your faith-based leaders and your trainers and your leader and everyone that's in the field, so that if we can coordinate on how to reach out to leaders, how to reach out to women and men, how to help fathers and improve their collaboration as well, that's really valued. Behavior change can be challenging. All of us recognize that sometimes we need to change the way we're doing things. When I was a young pediatrician, I had this concept that if I just told my patients what to do, they would do it. When that didn't work, I decided I needed the perfect pamphlet, okay? I figured if I just had the perfect pamphlet, that I could hand it to them and they would read it and suddenly their asthma would be under control, okay? And then I realized that wasn't working, so we thought about how do you motivate? How do you change your attitude about stuff in terms of changing behavior? And I had this one colleague I worked with who said that she was incredibly successful in getting her parents of asthmatics to never smoke again. I was astounded. I said, I need to know how you do that. And she said, when they come in and I smell smoke on the mother or the father or the kid, she said, I turn to them and I say, Smoking around an asthmatic is child abuse, and I'm going to turn you in for child abuse if you come back in like that. And I thought, oh, well. But of course, they never came back to see her. But as though we don't know whether they quit smoking or not. So we've looked at knowledge. We've looked at the pamphlets and the handouts and stuff. We've looked at motivating. And the next thing you need to do is you need to look at, well, how do I give them the skills to change? And so we've spent a lot of time, whether it's in family planning or asthma or diabetes or anything, teaching people how to have the skills for change. All of those are critical. Everyone we talk to needs to have the knowledge about why it's important to change behavior. We need to be able to motivate them. We need to be able to give them skills. But the determining factor that we see over and over again is not just those three things of knowledge, attitudes, and skills. It is the support system. If the support system doesn't validate that behavior change, a lot of times, even if it happens, it's short term. That's one of the most critical roles that I see for our faith-based leaders and for our faith-based health caregivers. Because if you can relate to somebody in a way that they feel not only informed and motivated and trained, but supported, it's much easier for them to maintain that behavior over the years. And I think that's a skill that we appreciate in the faith-based community and that we also want to strengthen and we also need to learn from. So we appreciate very much what you're doing on that. One of the areas that we really want to engage you on, it sounds like you already had a discussion on this morning, is engagement of men and boys around these really important issues. Really, it's so critical for us to get men in. As you no doubt talked about this morning, the HIV diagnosis for men typically is later than for women or youth, even though youth is delayed as well. So we need to get men into the healthcare system, and one of the windows through which we may be able to draw them in may be around family planning, especially if it's looking at how to gain couple consensus about planning for their family and spacing their children and method choices. But if we bring them in then, perhaps that's a good opportunity to talk to them about TB, HIV, malaria, and also just care for their family. We also recognize that if you can build communication around some of these sensitive areas, I was talking to Lois Quam a month or so ago, and she was telling me about a course they had for young men, and she asked one of the young men what was the most important thing, and he says, I can talk to my wife about hard things now. And I think that's one of the goals. We want men all around the world and women to be able to talk to their spouse about hard things. And that does create not only a bond there and more compliance because you're building the support system again, but we are looking at how we can help people be change agents around these important issues as well. So the world is changing. USAID is changing. We have good opportunities in front of us. We are looking at the place in life where we're changing from being just family planning to where we're looking at family-centered care and where the integration of those services can really make a difference for many, many people. So thank you very much.
Thank you very much, Dr. Golden. You've set us on an excellent track. Could I invite the panel to come up and take their assigned seats? We will not do an introduction of each panel member because you have very nice biographies that have been prepared. But basically, we will start with Dr. Alonso Rosales. Then Susan Oceri will come up and briefly from the floor and inspire us. Both of them are speaking from the World Vision point of view. Then Victoria Jennings will reflect on experience, and Jeff Jordan. And then to bring it all together, we'll have Beth Schlachter from FP 2020. I've been invited, I think moderators should be extremely limited in their comments, but so many thoughts came to me as I was reflecting on the panel today. I thought I would at least put 6 issues on the table that I think directly or indirectly will emerge in this discussion. It is clear that family planning, which in many ways went to sleep in the years after the Cairo and Beijing conference, people talked very little about it. A lot of focus particularly on girls' education as the solution, which of course it is, but among others. But it is now really surfaced as really a life or death issue, particularly in some parts of the world where the population growth rates threaten the welfare of families as well as the welfare of the planet. But some of the issues that we're encountering, first of all, this is not an easy topic. I think we should emphasize that. But I think we also need to be aware of the complexity of some of the religious critiques of family planning. And here I'm thinking particularly of some of the extremist narratives, where there is a narrative that family planning is a Western plot to limit the size, particularly of Muslim populations, and a lot of concerns around those issues. So I think that we need to be aware of some of those sensitivities. And that brings us, I think, to a second dimension which has particular importance, which is the link to the fragile states, which is, I think, a central preoccupation of the development world. The countries that are not doing as well, the places where things are slow, where governance is fragile, which I think puts a particular emphasis on SDG 17, the question of partnerships. But what does that mean, and how do these partnerships work? So I think that's a second sort of underlying theme that we'll hear about, at least from some people. The third issue is that it takes us squarely into the complex issues of women's roles and gender relations. And with family planning, in a sense, at the center of those issues, you don't have to look very far to come to domestic violence, which was a topic on in the session this morning, child marriage, education of girls, but also women's livelihoods, relationships within the family. So I think we should be aware that we're right at the heart of some of the most complex issues in the behavior change that you're talking about, which is changing the relations between men and women. The illustration of the healthy timing and spacing of pregnancies as a way of framing an issue that opens up discussions, even with very conservative people, I think, is an example of the challenges, but also the possibilities of communications, without even taking into account the issues of social media and the transformations that are taking place. The role of misunderstandings in family planning is an enormous one. So I think that the issue of the strengths, in fact, the genius of many faith leaders in communication is one of the assets that we're looking to. But we also have graphic and constant illustrations of the sensitivity of language and the importance of how you use language on these sensitive issues. And then a final comment is that we are looking here at gaps in knowledge, at what we're learning from experience, with a view to looking strategically at this complex issue of how to engage the enormously complex and diverse faith communities of the world, the 85% that people are affiliated with in some of these global problems, and in this case, the very sensitive and critical issue of family planning. And it's different in every country. And in every country, you need to start with the strategy of how does the religious community work, what's its relationship with governments, what's its power structure, what are the sensitivities, but then also go to the community and the individual level. And we also see the vital importance of these issues in global transnational institutions, including the United Nations, but in a number of other institutions. So it is an issue that goes from an individual or a couple all the way to the global stage, with strategic and practical issues at each stage along the way. So that's a brief framing of the discussion, and I'm sorry you've been standing there waiting
No
to
problem.
speak.
I
So
hope that
over to
doesn't
you.
count, right? For my time. Otherwise, I can go and sit.
No, it doesn't.
Okay.
That was my time.
Should I start? Okay, so good afternoon. Thanks to Wilson Center for having us, and thanks to World Vision for putting this together, to Susan and Gloria. Let me begin by acknowledging our colleagues in World Vision Ghana and World Vision Kenya, whose efforts are ongoing to improve the development of those countries. Likewise, our profound gratitude to John Templeton Foundation for their support to this line of research. In choosing the title of my presentation, in an inclusive time, does religion have a role in sustainable development goals and universal health coverage era? I wanted to go beyond the research that we're going to be presenting today, which is focused on reproductive health. And I wanted also to be a little bit provocative in terms of thinking or reflecting what is the role that faith leaders play in the development and sustainability of their own communities. Because I really think that they really play a huge role. The UN Global Strategy, and I have to move this, the UN Global Strategy for Women's and Children's Health, the Every Woman, Every Child agenda, acting on the call, universal health coverage, and ultimately the Sustainable Development Goals all have one thing in common. They're very ambitious. And because they are very ambitious, they must have good health systems. And not only good health systems, but also stakeholders for different sectors in each of their communities. The UN Global Strategy labels community health work as an essential component of health system resilience, and community engagement as one of the 9 action areas. However, operationalizing community work, it's proven to be problematic. As a community-focused agency, World Vision operates its programs based on a life course approach, which within a health ecosystem. And this health ecosystem has 3 main components. One is healthcare needs, the other one is health services and systems, and the other one is an enabling environment. For each of these components of these ecosystems, World Vision has developed an operational model. I'm going to be talking today of one of these models, Channels of Hope. Channels of Hope is a model that uses faith leaders and faith groups to address local health-related issues, advocate against harmful practices, and advocate for quality services. Channels of Hope was developed to address HIV-related issues. And after demonstrated impact on reduction of stigma, the model has started to integrate other initiatives related to health. Today we will be presenting the findings of integrating reproductive health messages into a Channels of Hope delivery platform. The activity took place in northern Ghana and Kenya, and it was, as I said, funded by Templeton's Foundation. The purpose of the activity was to assess the feasibility and effectiveness of faith leaders' support for family planning. And we worked under the hypothesis that Channels of Hope will increase population knowledge on contraceptive methods, contraceptive demand, and contraceptive use. We used a two-arm before and after quasi-experimental design, with Channels of Hope only applied in the intervention arm, whereas comparison arms included only World Vision regular programming. Activities were implemented for 32 months only in Kenya. Due to delays in ethical approval, in Ghana we were able to implement the activity only for 26 months. To collect information, the study adapted a USAID MCSP reproductive health survey questionnaire with 13 data points variables. The questionnaire was administered orally using an open data kit platform by trained collectors. A two-stage random sampling frame was utilized to select the respondents in intervention and control sites in both countries. 36 clusters in Kenya, 24 clusters in Ghana were selected. With a total population of 4,372 participants in the study, with 50% divided by intervention and control arm, or a 1-to-1 ratio. No major demographics differences between intervention and control arms. A total of, 6 of 10 participants were 20 to 20 years of age, 9 of 10 were married, 6 of 10 had no education, and 8 of 10 had less than 5 years of education. Half of participants were housewives, and the other half identified themselves either as a pastoralist or farmers. 7 out of 10 were Christians. There were some differences at the country level. One of them was that in the Ghana area, 50 and 50 were Muslims and Christians. Of 12 contraceptive methods investigated, only 3, male sterilization, female condom, and lactational amenorrheal method, did not increase from baseline to endline. Respondents reported highest knowledge on injectables in male condoms, while emergency contraceptive and intrauterine device were the lowest. As noticed in this graph, there were positive percent points gains in contraceptive knowledge in both arms, although percent point differences between baseline and endline were much more stronger in the intervention arm. Implants, injectables, and female sterilization were the methods with greatest gains in knowledge in the intervention site. The magnitude of change was much more intense in the intervention site when compared to control sites and is statistically significant. The odds of moderate contraceptive use in intervention sites were 27% higher than in control sites. These results were statistically significant. In control sites, there was no change, a significant change. Intensity of impact was felt stronger in the Kenya intervention site, where the odds of modern contraception use was 1.5 times higher than the control site. Further analysis of these indicators to demonstrate differences between districts is shown in this table. Fertility intervention change were statistically significant in all districts and independent of intervention penetration. Districts in Ghana showed substantial increments above 30%, while Kenyan experienced moderate change with a less than 50% difference. Moderate contraceptive method mix showed a substantial and significant increase of more than 40% percentage points in the Kenya intervention site, while in the control site, although showing a positive direction, change was not statistically significant. The intervention site in Ghana showed no movement in either direction. Total unmet need increased substantially with a more than 20% gains in both intervention areas, Laisamis and West Gonja, both in Kenya and Ghana, as well as in the control site in Ghana. The control site in Kenya experienced minimal and no significant gains. Oops. Well, using the number of the responses to the variables of implementing COH as a dependent variable, we did also logistic regression estimates. And we estimated the probability of experiencing increased knowledge, use of demand for contraceptives, and group differences in the pre and post intervention period between test and control cohorts. Accordingly, the intervention resulted in a significant effect on future fertility interventions, family planning method mix, total unmet need for birth spacing, knowledge of 3 or more modern family planning methods, knowledge of the ideal waiting time of 2 or more years for next pregnancy, and knowledge of problems associated with having another pregnancy after having 4 births. Moreover, in Kenya, the prevalence of modern contraception use increased by 32% points in the intervention site. All in all, the evidence obtained by this study seems to demonstrate that World Vision's model Channels of Hope is acceptable to faith leaders, an effective intervention among women in reproductive age to increase knowledge and demand for modern contraceptive use in rural areas of northern Ghana and western Kenya. The locations both in Ghana and Kenya where this study took part were difficult in terms of access because of terrain, but also because of communications due to language and cultural barriers. Other limitations are inherent to the design of this study. It was a quasi-experimental. Regardless of the outcomes of this study, the big challenge for all of us in World Vision is to integrate in a simple and efficient way. So these vertical type of models can be applied through a life course approach, life course lens, and in a defragmented way. It will not be easy, but I think it can be done. Many thanks.
Good afternoon. In continuing with examples of World Vision's projects in healthy timing and spacing of pregnancies, I'm going to present a couple of projects that we've had mainly in Kenya, because most of our work in East Africa started in Kenya. So on the screen, you'll see about 5 projects, and mostly we try to integrate the healthy timing and spacing messaging or framework into existing ongoing Ministry of Health programs. And so our USAID funded a project under the APC, the Advancing Partners in Communities project, is integrating HTSP into ongoing maternal and child health and primary health care project in Garbatula in Isiolo County. We also have the John Templeton Foundation, which Alfonso has just spoken about. Our funding from the Pfizer Foundation is looking at integrating HTSP and family planning into immunization clinics, so that we have a one-stop shop for women, not having any missed opportunity. We just concluded our baseline report, and so that's another. We have results that we can share in the future. In addition, we had a major project that combined advocacy and family planning programs in the field. And after that ended, that project was funded by the Gates Foundation. We have received another funding from the John Templeton Foundation to scale up the high impact practice that family planning does work, helps families to be healthy and strong and children to thrive. And so we are scaling up the Moment Project funded by the Gates Foundation from one sub-county in Seaya County to all of the whole county, which is to 6 sub-counties. So we're moving from a population of like 170,000 to a population of 1 million, and the scale-up is covering a period of 2 years. So just to give you a flavor of what Catherine said, we are looking at moving from the community, from the individual to global. And so our vision, in addition to what Dennis had earlier said, that we started family planning work about 20 years ago, and we have come thus far. We are looking to go further to reach women and children and have the next generation of children thrive. And so recently we've been working closely with the Ministry of Health in Kenya. They came up to see our work in Seaya County, in Isiolo, and the other places that I had mentioned. They see the family HTSP and family planning. HTSP opens the door to talk about family planning in various geographic locations, whether Christian, African traditional religion, or Islam. And so they are taking on the challenge of scaling up HTSC. They're going to be working with World Vision to scale it up, and currently have included it in the National Family Planning Training Curriculum that is undergoing validation. As a follow-up to Ghana's operations research, the National Council on Population and Development is also interested in working with World Vision Ghana and the Ministry of Health in looking to scale up the operations research and education and information on HTSP and family planning. And as an organization, we have come thus far from 2 decades ago to our current status. So we are thinking that since the African region has various religions, as mentioned by Catherine and Dennis, and I think Dr. Alma Golden, we think that it is a movement that we can spearhead and create and spread the HTSP message to improve or to increase the platform to talk about family planning and create demand and voluntary use of modern methods of family planning. So with that, I would like you to sit back and enjoy a video from one of our projects in Kenya on how we are using channels of hope and healthy timing and spacing of pregnancy to influence the use of modern methods of family planning. Thank you.
World Vision Kenya is a major player in Kenya in maternal child health, nutrition, and HIV programming. In the year 2015, World Vision Kenya reached 66,000 children through different initiatives, and our strongest area is through working with community health volunteers. Ministry of Health is our strongest and our largest partner. We work to strengthen the health systems in this country and to build resilience so that our communities are better able to take charge of their health, nutrition, and HIV. One of the innovations that World Vision is recognized for is healthy timing and spacing of pregnancies. And we have partnered with faith leaders to be able to educate communities about healthy timing and spacing of their pregnancies. And faith leaders are able to deal with the barriers, the community barriers that prevent women from accessing contraceptives and also timing and spacing their pregnancies.
We were trained on maternal and newborn child health, stroke, family planning, It was really thorough. We embraced it as faith leaders. When we came back, the first thing we did, we formed a group in our churches. And these groups are called Congregational Hope Action Team.
And in Siaya County, we have partnered with the Ministry of Health, the county government, to be able to increase demand for healthy timing and spacing of pregnancy services. We have educated community members, women that are available, the temporary methods, the permanent methods, so that women have a choice to choose which contraceptive they prefer.
The healthy timing and spacing has helped us so much. In this facility, initially, we only used to offer two kind of family planning methods. That one basically injectables and pills. And injectables used to lead. Why? Because remember, these mothers are coming from the community. And initially, the community were not empowered. And they could hide coming for these methods. So we only used to give pills and depots. That was so high. But currently, they are offering different kind of family planning methods. Even the natural family planning methods are like beads. They're all here, yeah? And we are giving them to mothers.
We've also educated men on the importance of healthy timing and spacing of their pregnancies through Moment, because it's about time that men work with their partners to be able to support them in this journey as they get children, so that every time the mother goes to the clinic, they go with the partner.
The concept where the Moment implemented by using different stakeholders, especially even having like the male champions, because reports has been the male partners are like contributing to reduction in uptake of family planning. By involving some of them as the champions, this we have seen really the involvement of male really now being more active, and basically would relate that as really making us increase the uptake on family planning.
This is bringing very good results, because we are seeing in Siaya County that more women are able to space their pregnancy. The benefits of healthy timing and spacing of that enough time to recover. It also gives the child enough time to be able to grow in terms of nutrition. The mother is able to focus on this child, breastfeed this child exclusively for 6 months, and also when complementary feeding begins, the mother is able to continue breastfeeding up to a period of 2 years.
As a result of that, the community now, you can see, it is green. Economically, it has gone up. Mothers are able to do things. They're able to take part in small-scale businesses and even farming, because they have that time, that spacing, yeah? And even the financial status of the community has gone up as a result of this partnership and empowerment.
Influencing these positive actions by our doings or by our daily way of life is actually promoting the healthy society that we want. So we are the agents of change.
World Vision Kenya is a major player in Kenya in maternal child health, nutrition and HIV programming.
Thank you so much. Thank you.
Well, I certainly can't top that video, so I hope you're able to get my slides back on. Thank you so much. Thanks to the Wilson Center and to World Vision for putting this together. Also, IRH is a Templeton grantee as well. So many thanks to the foundation for not only putting on this today, but supporting the good work that's being reflected here. Also, of course, thanks to Dr. Golden and to USAID and the many others with whom we've partnered over the years. Sure, I can get this together. I think that most of you know that the Institute for Reproductive Health has been working with faith-based organizations and faith leaders for over 30 years. You probably also know most of you do, that we started with a grant from USAID to conduct research and provide technical assistance in support of fertility awareness-based methods of family planning, part of the agency's Informed Choice portfolio. While our own mandate has grown beyond this, we have remained true to that core, and it still represents, I think, a unique capability or a unique focus that the Institute brings to this work. Today, IRH works with PVOs, NGOs, governments, research organizations, multilateral entities, and more around the globe, but faith communities and organizations remain central partners in moving forward an informed choice agenda for family planning. And here's why. In virtually every setting in which we've worked, essentially supporting and strengthening local organizations who serve their communities, gathering and sharing evidence, faith is at the heart of the culture and of the social norms that we experience. Increasing people's ability to improve their lives through healthy timing and spacing of pregnancies requires, it doesn't just slightly benefit from, it requires partnerships with faith-based organizations and faith leaders. Whether we at IRH are working with Tear Fund to help Protestant faith-based organizations in Democratic Republic of Congo implement a program called Transforming Masculinities that explores religious texts to uncover themes that promote health and wellness, or supporting Catholic networks in Rwanda and Uganda to train their community health volunteers to provide family planning counseling and services in rural areas and to integrate their service statistics with the Ministry of Health, or working with Mamansar, a Muslim women's organization in DRC, to help them provide accurate information and advocate to their religious leaders to create a positive environment for family planning. These partnerships are part of the fabric that moves the healthy timing and spacing agenda forward, worldwide and locally. More recently, we've been working on an innovation to make fertility awareness methods much more widely available, developing and testing a smartphone app so that essentially women and couples can use a fertility awareness-based method just with information on their phones. And the faith-based organizations are the first ones to step up and say, how can we support this? How can we guide messaging? How can we support couples? Because messaging can be just inserted right into the app. We want to be involved. This is just the beginning, but I know that we will be relying on these partnerships going forward. So I'd like to share with you a few of the specific examples and lessons learned. About 10 years ago, we wanted to better understand the landscape of faith-based organizations and their involvement in family planning. And we supported our colleague organization, Christian Connections and International Health, and I'm sure they're represented here today, to do a survey of their members, which pointed to two things that were just so clear. The one is language, the importance of language in communicating about family planning, and healthy timing and spacing of pregnancies clearly meets that goal. And also the need for clarity, quite frankly, and speaking of controversial issues, Catherine, the need for clarity between family planning and abortion, which unfortunately remains linked in the minds of so many. We conducted interviews with key informants in the global and country levels, looking at both Christian and Muslim faith-based organizations. And we presented these results along with those of CCIH at a consultation at Georgetown in 2011. And we found that faith-based organizations, let's see if I can get to the right slide here. What have I done? It's probably me. Okay, while you're working on that, okay. We found that faith-based organizations were beginning to engage in this area. They were open to strengthening their work. That's what I did, but who knows? Okay. Again, there was the issue of language and also the importance of who delivers messages. It's not me. It may or may not be you, but it certainly needs to come from within the community. Again, lots of common ground and opportunities for partnerships, but areas of discord as well, including abortion, access to family planning among unmarried youth, and disapproval of some family planning methods. And here's what we heard.
You're pushing the blackout button, push this one.
I'm pushing this one. Thank you. Maybe you could just stay here and then that way we can. Okay, so this is what we heard. Islam supports the health of the mother. It's an issue of language, a lot of misperceptions. Dialogue is how we move forward. And harking back to this morning, and I'm very sorry I wasn't here, but talk with men, include men in this equation. It's absolutely critical. So recognizing the potential in this area, we've worked alongside local organizations in several countries to involve religious leaders through sensitization workshops, equipping them as champions for healthy timing and spacing of pregnancies. We've also provided technical assistance to Catholic Relief Services to develop a couple-friendly, effective family planning approach in line with Catholic teaching for integration into multi-sector programs led by CRS around the world, multi-sector including nutrition and lots of other development programs. Strengthening the capacity of Christian health associations. Recognizing that family planning is still a major issue globally, in many African countries, church-based health facilities, as we know, provide a significant percentage of healthcare services, but family planning is often lacking. Where it is being provided, some studies have shown that the faith-based health sector is very critical in providing services, especially to the very poor, and they're also located often in remote rural areas. So we've been working with a number of Christian health associations in Africa to strengthen the capacity of their family planning programs using a systems approach, as noted on this slide. And this work has led to a number of other important findings. We see the value add of this work as being so many things that I couldn't even really create a slide about it. But strengthening the collaboration between faith-based organizations and ministries of health has been very critical. And when the faith-based organization comes to the table with clearly something to offer, clearly something measurable to contribute, it makes a huge difference. And should we also say that ministries of health, while they are not faith-based organizations, consist of many people who are inspired by their faith and who appreciate the connection with faith-based organizations. It certainly increases family planning access, increases the method mix, engages with community health workers, community health volunteers. Engaging religious leaders as champions has been absolutely critical. I know there's a question to be raised about that. You know, what is the role of faith leaders really? And like in any case, it says it's individual. A leader, really? What kind of leader? How does this leader engage with people at the community level? Improving couple communication and involving men is something that we're seeing over and over in the programs that we're working in. Men are coming to the health facilities. Men are meeting with the community health volunteers in their homes, et cetera, to engage in discussion about family planning, to be supportive of family planning. Some of the pictures that you saw in the video that Susan just showed, I think give a very clear example of how that occurs. And also activating Catholic family planning service delivery, which is something, that is a stretch for a lot of people, a stretch for a lot of organizations. But I think we've found ways into the system. We've found ways to work with the system, work with these people as partners, and that it's going well. So many lessons learned from our experiences with faith-based organizations, and here they are. Family planning can be acceptable. It can be acceptable among many Christian and Muslim organizations, and fertility awareness methods are an important entry point. FBOs and religious leaders are important partners in reducing barriers and also improving male involvement. Language is important. This is probably the third time I've said that, so anyway, it is important, really it is. And when faith-based organizations are involved in family planning, just as Alfonso showed, uptake increases. That's our experience as well. Often among women who have never before used a family planning method. Quite often meeting people with an unmet need who are simply not going to access services, other kinds of services, and have those needs met. So those are some of the lessons that we've found. I want to thank you again for helping me with my slides. And I'd also like to thank particularly my colleague, Lauren Venink, who's in the room. I just returned from travel yesterday, and it fell to Lauren to pull together a lot of what I shared with you today. So many thanks to her as well. Thank you.
Over to you.
I'm all right. It's a little cold up here.
I have to say, we know that the air conditioning works. So if anybody thinks climate is not an issue, it is. Sorry, bada boom. Like everyone else, my name is Jeff Jordan. I'm the president and CEO of the Population Reference Bureau, not a faith-based organization, a research, policy, and advocacy organization, but proud to be longtime partners with the faith community on a whole host of activities. And I appreciate that there are many in the audience who both represent faith-based organizations, but also are people of faith in how they operate within whatever sector they're in, whether that is government or the private sector. And it is important that we continue to reach out and find that commonality as we move forward, particularly as health professionals. We have to continue to engage the faith community. If we don't, then we are actually shooting ourselves in the foot for trying to move our work forward. And today I wanted to talk a little bit about, again, where do we bring some of these messages around language, around who has the message and who brings the message forward, and some of what we've learned about engaging faith leaders using a multimedia platform. So let me back up and share with you both the product and the process that we've used to engage both decision makers, cultural and political leadership around a host of issues. Our presentations are multimedia presentations that blend reliable data, cutting-edge graphics, and stunning photos and video to convey clear and compelling and actionable messages. Now, we've created those for specific issues in single countries. Two of the examples in front of you, one is from Senegal around family health and family planning with the faith-based community, and I'll come back to that one. The second one is related to integrating population health and environment for sustainable development that was done for Kenya. But we also do these presentations from a global advocacy perspective, including the third example, which is harnessing the demographic dividend. And I'll actually touch that one again in a minute. So now I'm having paper problems, not technology problems. So what makes these presentations compelling is that combination of clear information and messages rooted in sound data and evidence. So the data matters, with powerful visuals. They become tools to raise awareness, to initiate dialogue, and to spur action among decision makers on critical issues, including topics like the intersection of faith and family planning. And while the presentation itself is an important product, it's not an end in and of itself. It's really the tool to help both leaders and their audiences better understand and take action on priority issues. And we know that these presentations are both being used and that we're having results from them. They've been shown to thousands of folks in various different global and national and subnational gatherings, and at least 6 heads of states have worked with those. And I will turn them the other way. So here are a couple of examples of impact at both national and district level. I'm really just going to focus briefly on 2. The first one on Kenya. We produced an engaged presentation looking at issues around nutrition. It was used by the First Lady in Kenya. She used data from that in quotes, emphasizing the importance of investment in nutrition for economic growth. And then we did additional advocacy work using that presentation with governors and with First Ladies and commissioners. And in the end, 3 counties in Kenya increased their budget allocations for nutrition to work with children. And that, that's what we're looking for, is that local investment in and bringing their own resources to bear, improving the lives of all. One more is the Nigeria example. Advocates used the global engage that I showed before on harnessing the demographic dividend, and they used it to open and frame a plenary session in Nigeria at a national summit on the demographic dividend. Now, this meeting was hosted by the president. It included the ministers of about 6 different departments within the government and a host of other officials, a variety of donor agencies, including aid, the UN system, your typical cast of characters at that level meeting. For us, what was important was the video was used at the beginning of the summit to make sure everyone was on the same page, that the audience understood the concept of the demographic dividend and what Nigeria's harnessing of that dividend could do for economic growth and sustainable development. It's interesting for us in particular because we didn't develop that messaging for Nigeria. It was a global engage. It was picked up and used. It was not used with project funds or with anything else. And so it was really important to us that it was brought back in, that it remained a valid message and could be used by anyone. So we were very, very pleased to see that happen. So what is the process? Because it's really, while the engage itself and the multimedia presentations are a product, it's the process that really is probably more crucial and critical to impact and to success. So the engage process includes close collaboration with local experts and advocates. So while PRB may support the process, it is really our partners locally who shape the result. And these products and processes have been financed both by partners like USAID as well as the private foundation community. So for each engage presentation, we establish a working group of key stakeholders. And I'm going to come to the example of Senegal with faith leaders, researchers, experts, and advocates. This group then guides all aspects of developing the presentation, from identifying the goals and target audiences to framing key messages, suggesting data sources to complement those that we bring to the table, and to provide input on photos and graphics, and finally to help define the communication strategy. We found that this collaborative process ensures that the resulting product is relevant and useful for local champions, and reflects not only the best data available, but frames the messages effectively to achieve the goals. So again, back to language and messaging. And what we produce is not just a presentation, but really a package of materials. So typically there's something you'd call a clickable presentation, which is basically like a PowerPoint that a narrator can stand up and deliver to a live audience. We also then produce a narrated version of the presentation that runs as a video. We have user guides that include instructions on how to use the presentation, the script, suggestions for dialogue with the audience, reference materials, and message handouts. And all of this gets replicated in local language. So depending on the country, that may be a national language, but it may also be other local languages. Now, we found the Engage approach has also been particularly effective with the faith community, and we've produced Engages in 3 countries, Kenya, Malawi, and Senegal. And we were doing that in an effort to reinforce the efforts of faith leaders, both to help them understand how supporting family planning aligns with their faith commitments. The Engage process of convening the task force to guide the messages and define the target audience helps to cultivate the task force members. It helps to, in this case, bring faith leaders in as family planning champions. This gives the champions the confidence and understanding of the health issues as they deliver their presentations, and it helps them in working with their constituents and sparking dialogue around these issues. Our most recent Engage, and those 2 pictures were from faith leaders in Senegal, is one that was prepared for Senegal and was launched earlier this year. The presentation is currently only available in French and Arabic. Otherwise, I would have played a short clip. But there will be visuals coming here back from the whole process. So these are the leaders that we were working with. We worked with the interfaith group of religious leaders, the Cadre des Religieux pour la Santé et Développement, or CRSD, and actually along with the World Forum for Faith and Development was a great partner in this, and the Senegalese Ministry of Health. We developed a presentation to support Senegal's ongoing efforts to significantly reduce its maternal and child mortality rates through reproductive health and family planning strategies. The presentation acknowledges the strong relationship between reproductive health and family planning with traditional religious values that support family health. And the presentation messages align with Senegal's package of projects and reforms known as the Plan Sénégal Émergent, which emphasizes social and economic reforms, including significant investments in health. In February, the Ministry of Health launched the presentation in front of nearly 1,000 people as a kickoff to a week-long public fair celebrating maternal and child health. Paper. The event also served as a culmination of our activities with journalists over the course of a year to draw increased attention to family planning priorities in Senegal. The launch event and the key messages from the presentation were headline news over the following week, and it included stories and radio coverage and stories in 7 print media outlets. Following the launch, the partners in Senegal carried out a series of community-level events to share their presentation and foster dialogue with religious and community leaders. The series of events has reached an additional 1,000 people, and in every meeting, leaders have pledged their support to advocate for family planning and reproductive health for birth spacing. These religious leaders have appreciated the clear data in the presentation and that the tool combines religious arguments with scientific and technical data. Religious leaders have also been glad that the presentation appreciates the important role of the religious leaders themselves when it comes to the topic of family health, and they've been willing to engage in discussion because the messages are so respectful of their values. In addition to the 2 high-level and community meetings, the presentation's been shown twice on national TV in both French and in Arabic. So I'll close with just 2 extra lessons that we seem to be taking from that. One is that the partners continue to share how much the religious leaders in particular are glad to see their own influence being highlighted in the video, reinforcing that who's giving the message and who's involved in the process. And for those familiar with Senegal, Senegal is really, I wish it were not so unique, but it's unique in the mutual respect that seems to come out between the Muslim and Christian communities. And there seems to be an interesting confluence in what's come out in the messaging here, and that we've been getting feedback that there have been a lot of aha moments when participants have recognized that their respective religious texts seem to be quite similar with respect to health and the importance of mothers and children. So a really nice, unintended, but I mean, I guess it kind of makes sense because of the process, mutual reinforcement across. And so we're excited about what that continues to do. And so I just want to say that I have to admit that there are times that I'm surprised at how much we wax and wane as a community concerning our involvement with the faith-based community. I've been doing work in this field for about 25 years, and I see a host of friends and colleagues from a variety of organizations who've done this work as well, and really applaud that. And I think that we need to keep lifting up where and how we continue to integrate and to operate together to achieve the health sector and the SDG type goals, but recognizing how important faith and the faith communities are to that achievement. And finally, a shout out to Marissa Yiki on my staff, who I was out of town as well and helped pull most of this together for me. Thank you.
We'll turn now to Beth Schlachter, who will pull it all together and move us into the phase of exchange.
Thank you, Catherine. And this mic does work. So I think I'll stay here in spite of the rather fresh atmosphere that we're enjoying on the stage. It's a tall order to pull together such a complex conversation. I appreciate the opportunity, and I'm grateful to the Wilson Center and to World Vision for inviting me to play this role today. And in preparing for this moment, what I thought could be most helpful in terms of pulling together the commonality is to take that and share with you how we see this coming together through the partnership work that that we have the honor of supporting through the FP 2020 Secretariat. You've all made the strong and compelling case. There's no doubt that working with communities, particularly communities of faith, all need a very specific approach. And the value of working through faith-based interlocutors is clear. We're working around the world with and among and for communities of faith. And so respect for their values, for their approach to life, for how it is that they want health care to be provided to them has to be paramount in our approach. And that's foundational to the FP 2020 partnership. USAID has been a core partner to FP 2020 since we launched in 2012 and brought that energy back to the family planning sector because, as you said, it had waned over time in terms of global interest or that global approach to family planning. In terms of ambitious goals, we set one for ourselves. It was reaching 120 million additional women and girls to provide them an opportunity to choose for themselves how, when, or if they would like to control the number of pregnancies they have in their life. The entry point to reaching people is through country commitments that they make for themselves. At this point, there are 42 countries of the 69 lowest income countries in the world who've made those commitments, and they've articulated how they want to approach their work in their countries. And many of those commitments include working with faith partners and include faith perspectives. Every 18 months, we work with countries who've made their commitments on a regional basis. In March, we were in Cameroon with all the Francophone countries. There's now 15 who've made their own family planning commitments. And many of them, they all develop an action plan for how they want to approach their work in partnership to achieve their family planning goals. And many of those include specific approaches and work with communities of faith. Now, when we have these workshops, we're working with governments, with donors, with civil society, and now with youth advocates as well. So they're forming really a shared partnership and a shared agreement around what their entry points and what their actions will take. And again, faith is threaded throughout those approaches. So there's no dispute that this is of incredible value. It's just the framing of daily life in the countries that we're working to partner with. It's also a key approach through the leadership of the FP 2020 Global Partnership. There are now over 100 commitment makers to family planning, or to FP 2020. Again, it includes many donors. It also includes many service providers and implementing partners as well, who articulate for themselves how and when they'll approach their work, and that includes working through and with faith partners. We're also excited that Cycle Beads are one of our few specifically faith-based partners to come to FP 2020. We would like to work more with the faith community, and we've done a lot of outreach around what kinds of commitments can be articulated for family planning, and we remain open to the possibility and the potential for those commitments and those partnerships as well. So I'd also like to put it to all of you and to faith communities to help us meet you where you are so that we can bring the partnership to you as well. There have been some attempts at that, but we haven't really gotten across the line in some of those articulated commitments, and we would like to find out how we can do that more effectively and learn from you. We have a leadership group at FP 2020 that's comprised of many of the organizations who are leading the family planning implementation in countries and includes many of the countries themselves. And in that leadership body, we also have an interfaith network that's represented as well, so that we have the specific input from the faith community that's at the table. But again, many of the people that are around the table are people of faith and bring those perspectives to the conversation. There's not a clean line when you come in as a service provider or as a ministry representative about whether you're a person of faith or you're there, representing the organization that you represent. All of these issues come out when we talk about family planning because, as has been so clearly articulated, when we talk about communication and language, it's very important that we look at all aspects of how we approach communities so that we can meet people where they are and through the approach that works best for them. So we work with countries. We work with the leadership bodies, all the organizations that are implementing for family planning. We work through the UN as well. We work through donors. And importantly, we also look to then partner with faith communities through these efforts as well, because we see faith partners as champions, as community leaders, as service providers, and as clients themselves and the very people that we seek to serve. So the partnership approach embraces people at all of those levels. But I'd like to bring us back to thinking about language and tools, because as we saw from each of your presentations, there are so many different approaches that we're going to need in order to be effective. And the evidence base that you've all built, and particularly I want to give another shout out to USAID through the investments that have come through USAID over 30 years that have helped to build that evidence base, not only provide us with effective approaches, but also provide the evidence that we need to make sure that those doors remain open and that we're bringing more people to these approaches because they're effective. And because at the end of the day, what we care about is good health for women and girls and for men and boys, for families, communities, countries, for all of us as we approach the SDGs. So I see the approaches that we have now as a very effective way forward. Catherine, you put out at the very beginning as well that there's an important nexus to population dynamics, to global security, and to working with communities of faith who not only provide stability in communities, but also are helping to ensure that they have the tools that help population growth happen in sustainable ways over time. And given the pushback that we see and some of the fear around those messages, it's really critical that we engage faith partners so that they can contextualize what we're talking about. When the government of Burundi made their FP 2020 commitment in 2015, they came here to Washington to launch that commitment. And when the Minister of Health from Burundi was asked what his inspiration was to make that commitment, he said that at that point in time in 2015, over 70% of litigation in Burundi was over land disputes. They had just come out of a genocide. And he felt that if they didn't provide family planning and contraceptive access and the ability for families to decide for themselves how they want to space time and limit their own childbirth, that they were going to have another genocide within a decade. So they're living within this context. And our ability to pull these together and to use the partners and the tools that we have to help them effectively manage growth within the context of security and safety, land access, which means access to money, to opportunity, to education, all of that is wrapped together. But he distilled it down to access to family planning. And he also said in Burundi that has to happen through faith communities because the population either has access to healthcare through faith-based service provision or because it was a barrier or just an entry point that had not been appropriately addressed. So if we don't contextualize these things ourselves and understand them, then we can't meet our partners where they are and help them to be able to overcome those barriers. So I'll stop with that. I really applaud all of you for being here. I thank you for including me and for FP 2020. And we stand ready to partner with faith communities as and where we can as well. And we look for your help and guidance on how we can effectively do that. Thank you.
Well, thank you all for a fascinating set of stories, but also very solid, indisputable evidence of the logic of what I think we share as a common belief. We're going to have a fairly extended conversation within the panel and then open it up to questions. But because we're a bit behind, I'm going to make this part short and then maybe give us a few minutes to exchange, and then to open it up to your questions. So I wanted to sort of take a positive and maybe a less positive. So I could direct it to someone or invite you, but just to take, this is not easy. We know that the topic is sensitive, et cetera, but the one topic that does seem to unite virtually all faith communities is difficulties with adolescence and sex between people who are not married, which, as we know, can't happen. It is impossible. But I wondered if you could give some examples of how you've dealt with that, or any sort of insights into it. And on a more positive side, if you have your dream and your wish, what should be the next steps? What is needed to translate the insights that we're hearing here into practice? So who wants to start on that?
I can start. Within these quantitative research that we did in Ghana and Kenya, we did a qualitative research as well before. And we found that most of male faith leaders were didn't like the idea of sexual education for youth. And most of their reasoning was that they were afraid that they would be promoting sexual relationships among. So that was almost, I mean, in Kenya and in Ghana, Christians and Muslims, it was the same. The difference was because we also had in these focus groups their wives. Their wives were totally the opposite. They wanted to get youth involved in sexual education because they thought that the young people needed to be informed about the contraceptives and the sexual transmitted diseases, et cetera, et cetera. So that was very interesting for us to know through this qualitative research about.
Our experience has been a little bit different from that. So one thing I'd like to just note, I mean, we're talking here, the words that we said were sexual education. And when you think about that, and when you think about the language that puts on the table, I mean, do you really want your 10 or 12-year-old to have sexual education? Or is this about what does it mean to be a responsible person in this society? What about your body? What is going on with your fertility as you go through puberty? How do you manage that? How does that shift your relationships with others in the community? How can that be handled in a positive way? So I think sometimes we ourselves, we don't think about it in a way that makes it palatable to people who would otherwise be more receptive. Now, that doesn't mean that just by saying the right words, that conservative religious communities are going to say, oh, sure, and you can talk about contraception in there too, that's fine. I mean, I don't necessarily mean to imply that would be the case, but take it as far as we can get it while talking a common vocabulary. I think we make better inroads that way. We make better partnerships that way, and we leave with greater benefit ongoing to the community because it's something that they can support and really get behind. It's not easy. You're absolutely right about that. It's not easy, and you can't please everybody. There will always be the extreme voices. You talked about extremism. It's extremism on both ends of the spectrum. And there certainly will be the negative voices out there. There will be people who are saying, if you're not opening full access to contraception to unmarried youth, then we don't want to work with you. And there are people who are going to say, if you so much as mention contraception to youth, we don't want to work with you. So, there's enough common ground that I think we can make good progress together.
Do you want to take the positive or the negative?
I would say somewhere in between. For me, a lot of this has to deal with both of the concept of where do we take the opportunity, and we tend to step back from it because we get caught up in the sex, or we get caught up in whatever is the sin, or however you want to do that, instead of flipping it back to what's the relationship, and instead using our faith practice to talk about what are healthy relationships between people. Because then you can start to focus on the gender dynamic. You can start to focus on all the other things that start to move us away from domestic violence or from, there's a whole host of things. So one is where you've seen programs come in from that perspective, you tend to have a very different, it destigmatizes it. It's not necessarily about sex, it's about relationships and what's a caring and loving and what does that partnership mean. How far you go in that relationship, even if you want to get into fluidity and gender fluid concepts and all the rest of that, that's going to depend completely on cultural and other kinds of issues. And the other thing I'd add is that I'm a policy wonk. That's my training, and that's what I've always done is the policy stuff. And within the church, this also happens elsewhere, and I say the church, or within faith communities, the difference between being pastoral and being policy are actually very, very different. I have worked with, nuns in rural Sudan who are quite happy to deal with family planning and have it out on the counter. And when the bishop comes in, it depends on the bishop. Sometimes that goes in the drawer, and then it comes back out after they leave. For some of the bishops, it is, no, this is our reality, and this is exactly what we need to be doing, because they are attending to individual needs. And so we also tend to get so caught up into, I can't go on record. I can't say this out loud, because if I say it out loud, it becomes policy. So where and how we encourage dialogue that gets at the needs of individuals actually helps us step away from pat statements that are one size fits all, because as we know, there's never one size that fits all. That's why language, that's why community, that's why all of those, that's why situation always matters.
Mm-hmm. I'll just build on what you said, Jeff, that situation always matters because the context for adolescence is different everywhere. In some places we have high rates of child marriage, and girls are being married between the ages of 10 to 14. And we have, I think the latest UNFPA statistic is that 2 million girls aged 10 to 14 give birth every year. That's not get pregnant, that's give birth. And that 95% of those girls do so within the context of marriage or some form of formalized relationship. So I would argue that in that community, those are girls who perhaps at a younger age need more available information because they're going to find themselves in a situation where pregnancy is likely much earlier in life than most would want. So when we talk about evolving capacities, because I think that was your important point, Victoria, that everybody doesn't need the same information at the same time, nor are they ready for it. So the readiness argument is important, but what's happening in their life is also important. When I was in Cameroon, we had a dinner, and I was sitting at the table with the Minister of Health and the cultural leaders of the community, and one of them said, well, no man would marry a girl unless he knew she could bear a child. So of course we have sex with them before they get married. So if that's the context, if that's a girl who's never had any education about reproductive biology, if she has no idea about contraception, that's a girl who is basically having sex with somebody because she has to. She has no choice. So if we haven't been able to support her with education about what that's going to mean and what she's going to face, then that's a girl that we've abandoned, right? We haven't met her needs somehow as a global community. So how we get to that person is really a difficult nut to crack. I'm not suggesting that it's the responsibility of any one person or any community, but I think we have to contextualize these things when we talk about them, because you're right, otherwise we end up on these polar sides of what we're talking about, when really what we're trying to do is give information and access to services to people who need them, and that we have to get to that together somehow.
Okay, just one comment before we turn to the floor. Yeah.
Okay, so I just wanted to clarify that I think when we're talking about youth and when we're talking about males in general, I think the platforms to deliver the message are the ones that we need to figure out which are the best. I'm not saying that probably faith leaders are not the best delivery platform for youth. I mean, that's what we found in our research. But in another research that we did in Zika, for example, during the epidemic in Latin America, we found that the health delivery platforms for male do not exist. So male population in Latin America during the Zika epidemic were underinformed because most of the messages were being delivered through the health services. Male don't come to the clinics. Right. So messages were not being delivered to male population. The same for youth. They don't come to the clinics. So my point is that we need to analyze really through this type of research, what are the mechanisms for delivering messages to these particular populations, and not trying to impose, and force the message on platforms that might not be really efficient or effective.
Good. Well, I would love to continue this conversation, but we also want to bring the audience into it. So please, if you want to raise a question, raise your hand, tell us who you are, and please focus on questions with a question mark at the end. So right at the back.
Hi, great panel. Nancy Harris from JSI, and I have seen World Vision programs in Garbatula, and congratulations, they're very well. Just a correction, the first USAID-funded programs, large-scale, community-based family planning were in Chogoria in Kenya almost 40 years ago. So my question to the panel, and then I have one more difficult question, is why is it so slow? Why do we still seem to be at square one trying to figure it out? It seems like 40 years is long enough for us to get something right. And why are we doing small programs in small areas and not very large scale programs that are going to have impact? And then the second thing specifically to the panel, I realize that most faith groups have an issue with abortion, but no one commented on the contribution to maternal mortality of high abortion rates and high rates of teenage pregnancy. So we can't keep our heads in the sand on these important issues.
Who'd like to take either of those questions? Jeff, you can start.
I get to skip the why are we doing small scale, since I didn't speak to the programs when we were doing service delivery. But I think that part of the answer to that is leadership. And I could name that for any country. I mean, for anybody who's worked with the U.S. Congress. Anybody in here? I mean, there's an ongoing, it's amazing, and you'd sit to think, didn't we with the last session just teach them all this? And didn't we, 10 years ago teach everybody this? And there is an ongoing, and until we have consistent leadership, whether that's in our ministries of health or whether those are at a presidential level or whether those are at a parliamentary level, that say that this is an important ongoing part, we're going to keep doing, and we're going to keep bringing the evidence, and we're going to keep finding our inroads where we do it, and we're going to keep showing each other and cheering each other on and getting through. But really, until you have leadership take a reign and say, we're doing this. This is the right thing. We need to continue it. Then we will continue to do great work in smaller areas as long as we find the funding.
Anyone else want to? Yes.
I would just add that there's a reason that we have an FP 2020 and not a Gavi or not a global fund for women's reproductive health. We don't have pooled funding because the world won't pool its funding with the U.S. The U.S. has the right to have its objectives and its opinions, but you can't have a pooled funding mechanism that can do large scale where you can't have a commonality or an agreement about how those funds can be dispersed. So to your point around Congress and this back and forth that continues to happen, it has a long-term impact on our ability to scale things and to do things in a way that isn't disruptive in the field and to our partners. So I agree with that. It's a challenge. Again, people have their perspectives, but the impact I think can't be overstated as well. So to your second point around abortion and teen pregnancy, I think that the argument is the evidence is well presented. It's indisputable that access to contraception reduces rates of abortion, and that the more women have the ability to plan and space their childbirth, particularly women who don't have the power within their relationships, marital or otherwise, to negotiate sex, if those women have access to contraception, then that helps to space children, and it lowers the rates of abortion. It's also indisputable, and there's a lot of evidence to that. So I would hope that access to contraception could be used by those who are opposed to abortion as a way of lowering those rates, because it's the most effective tool that we have.
In Senegal, one of the concerns is the level of infanticide, which comes as a surprise to many people because it's not part of the culture or the tradition. But I think it speaks to the desperation of the women who are involved in those situations. So I'm sure we could go on this for a while, but I saw some other hands, so why don't we go here, and then there was someone back there.
Thank you. My name is Diana Wajira. I'm a scholar here at the Africa program at the Wilson Center. And my question was about the role of media. How do we work with the media to ensure that they are an ally, especially in engagements with communities and policymakers on sexual and reproductive health and family planning, to avoid sensational reporting, as seen in Kenya, for instance, on provision of family planning to youth and adolescents and comprehensive sexuality education and such issues.
Is there somebody specific you wanted to answer? I'm sure everyone has answers to these, so if you point to someone, that would be helpful.
We'll point to Jeff, too.
The media is a target audience just almost like anyone else. I mean, and the media plays such a crucial role in leading kind of the fourth estate and keeping the dialogue going. One of the things that we're proud, AID as a partner helped us 30 years ago formulate a group called Women's Edition, where we work with women journalists, kind of mid-career. We create cohorts and bring them together to train them, to teach them about how to understand health data, how to understand what is happening and where and how to write the article so that they up both the kind of evidence and scientific content and what they're going on. And there's also an element of where and how we help them as a group break some glass ceilings, because editorial content in most of the world is controlled by men, quite honestly. And so, there are great ways to help the media understand data, understand good data, understand how to write really effective and good stories, and they're great stories of where those efforts have paid off. And we do that, but there are a host of organizations that try to do that. But like any other group, again, as we explode social media, as we explode other things, we have to have clear messaging, key messaging, crisp use of data, and other kinds of things that will capture and that people can write with.
Good. Did I see a hand at the back over there?
I think I was putting my hand down because I suddenly thought I have more comments than questions, but I'll try to format it into a question. I'm Sarah Craven with UNFPA. This has been a fascinating discussion, and I really want to thank the Wilson Center for gathering everyone today. And I think by synergy, I'm sitting behind Adrienne Allison, who 25 years ago, she and I worked with USAID and others to ensure that the Cairo process had a real faith-based engagement to it. And I think the U.S. should have been very proud at that time, because the U.S. delegation to Cairo had many faith-based leaders on it, and by sort of mimicking that process, many other country delegations also brought faith leaders to the process. So I guess I'll put the question on, next year is the 25th anniversary of Cairo. What creative ideas do any of you have in terms of how we change that dialogue or how we reframe the language to reignite that kind of amazing moment we had 25 years ago where the world came together?
Do you have a nomination for first person to answer?
I nominate Beth.
I was looking away. It's a great question, Sarah. It's kind of hard to answer sometimes, isn't it, when you don't have something that comes to the tip of your mind, because, I feel like we're in a moment where we feel an incredible push and pull, Victoria, in terms of what you described, both an incredible sense of sort of this fear of change, of cultural transition, of women really definitely stepping out and having a different role in the world, in addition to being a mother, that womanhood is an incredibly complex experience, and that, that it feels as if this transition is facing an incredible pushback. But then there's also a moment where suddenly it feels as if women's voices actually have the attention, and that people are starting to have those little aha moments of what sexual violence means, of what sexual harassment means, of the complexity of balancing all of those things. And so I don't see a middle to that right now, quite frankly. I just feel the tension of those two sides. I do think that faith communities can help bridge that in a way that almost nobody else can, though, because everybody else is identified with one area or the other, and yet faith seems to thread across it. So I don't really have an answer for you other than to say, you know, that I think that we have to keep talking to each other and asking these questions about how we get there together, because I don't think anybody's happy with the fracture that we have. It's scary. And we have to use those linkages that we have and take each other with a sense of trust when we don't agree on every point, that we're all working toward the same greater good. We just might define some of the pathways a little bit differently. But I'm really heartened by your example of what the U.S. delegation was 24 years ago, and what that proved. And I hope that we will get there again, and that we won't have a reprise of the Commission on Population and Development this year, which fractured over those breakages instead of coming together with the spirit of really wanting to have an outcome because we value women.
Jeff?
Just want to add one thing, and it would be interesting, along that spirit, but also thinking about Nancy's earlier comment, that we've been at this for a while, and is there a way to bring in, and it would probably take some kind of an outside donor. If there are any donors in the room, y'all can step up to the plate. Because I'm not sure exactly how we're going to host some of the events around that. But it might be, again, a fascinating time to reprise the spirit of that from ICPD, of where and how the engagement with and the understanding of the faith community and bringing these issues together. I mean, I tend to agree that it would be a great way to both share the evidence and the knowledge that we've continued to learn from this, but start addressing and start saying, where does our faith and where does our common humanity allow us a space to talk about some of these issues in a way that moves us forward and maybe gets out of the politics of the issue, because you can go at the humanity of the issue. I mean, I would love to see, and I think that there'd be a tremendous response from both partners who work with the faith community and the faith community itself to kind of come together and say, wow, this is the right time to talk about some of this, and we've got, and we can deal with that tension.
Yes. One of the main financier of systems, of health systems in every country is not even the government, is the user of those health systems. If you analyze the money that users spend per capita, it's much higher than the rate of the GDP or that the rate of international assistance. So for me, one of the radical and revolutionary ideas is, can we make the system, the health systems, more responsive to the user? Whether it's family planning, whether it's maternal care, whether it's child care, it doesn't really matter. I mean, it's the responsiveness of that system that needs to respond to the user. What are the needs of this user in this particular community? I think that's the revolution that we want. And I think that if we are able to work towards that, together with all these new initiatives, the universal healthcare and et cetera, then we're gonna really get the revolution, and then we're gonna get a scale and not project-wise interventions.
Victoria, do you want to have a last word?
Well, I was just going to say that at one level, Nancy and I have been in this business so long that it seems like everything that comes along we already did 30 years ago. But that may be saying more about us than it does anything else, Nancy. I think one of the issues that is just so cross-cutting to this discussion and others is the whole issue of gender inequality. And religion has often been used, quite honestly, as a mechanism for perpetuating these very entrenched gender inequitable norms around the world. But religion is often really, I guess you'd say, it's heavily influenced by culture. It sort of is part of the culture, but it's also influenced by culture. And so it makes it really easy to perpetuate locally held beliefs through these religious structures. But when you really look at religious texts of some of the world's major religions, they're also very rich with teaching on human dignity, protection of the vulnerable, responsible parenthood, marriage relationships, etc., in ways that are not as gender inequitable as the behavior and the norms that we often find. So I think just building on the positives that we can pull from that and engaging partners with those positive values that in fact are the basis of many of the world's great religions, that we have the potential to make some progress. It will probably take us another 40 years, though. That's the problem.
I'm afraid that we have to bring this to a close. We're a little bit over time, but I was given permission. Wanted to thank the Wilson Center, the World Vision, my fellow panelists, and all of you for your participation. I thought I would end with one vignette. I've attended for the past few years the Ouagadougou Partnership, which you may or may not know about, but the Ouagadougou Partnership, related to FP 2020, really is dealing with family planning at a very, very demanding Gates Foundation style approach in the countries with the highest fertility rates in the world. So it has been very technical, but they are aware of the importance of the religious factors. They're aware of some of them. I'm not convinced that they're fully aware of the threat of extremism in that area. And in being in these meetings, I'm between worlds, sort of at least economically literate and very much in the development world, but also in the faith world. And it is clear that there's a long way to go for these communities to be able to speak to each other and to communicate. So I think that if I had my wish, that is one of the issues, is finding the language, the platforms, the instruments, the people. But when you have these very technical discussions, you can just see some of the limited faith leaders, Christian and Muslim, et cetera, their eyes simply glaze over. For them, the development and family is holistic, it's very human. And so finding ways to bring these together, I think, is where the challenge lies as we look ahead. Because so much of this seems so obvious. The size, the importance, the trust levels of religious communities, their potential for influence, their gifts of communication, their moral authority. The benefits of the medical side are absolutely incontestable, and yet finding ways to have these worlds intersect in creative ways is what we're about. So thank you all very much.
Thank you.